And we're on recording. Okay, guys, let's go ahead and get started. We have a big class ahead of us, and this is kind of a pivotal moment in our career, your career as students. Believe it or not, you may not believe me, but this is one of the big moments because we have now completed all of the prerequisite information. And we're moving on to the medications proper, the actual drug classes. How neat is that? What do you guys think? Good stuff? Okay. I would like to make a quick note about people making sure that you come in on time. One of the issues that I always had when I was a student is, man, they never really seemed to care about attendance and stuff. It never played a big role in my grade. I was like, well, I'm always here. Why, it should play a bigger role. In this class, if you look on the syllabus, 15% of your grade is related to you showing up, being here on time. So it's a real big portion of the course. So I would, highly recommend that you guys try to get here on time. And I explained in the syllabus, and that if you are running late, you need to let me know. And I also say in there, if you come late, I would like for you to wait outside until the break. I don't like being interrupted when I'm trying to study and people coming in. I don't know how you guys are, but I'm sure there are a number of you that, struggle to concentrate and what have you, and you don't like all that additional stuff going on. And of course, 3 tardies will be in unexcused absence, and then we'll have to do a student improvement plan. So I do take that pretty serious. I don't know how the other classes are, but I do take attendance and being here on time very serious here. So just to let you guys know that, just emphasize that. And we only have 2 hours a week to cover this pretty important stuff. All right, so moving on. So this is a great day. We are now moving into the drug classes themselves. And today is going to be a pivotal lecture because these are the most important medications that we give, the bronchodilators. So before I go ahead and pull up the slides and all that, let's just go ahead and review. Let's talk about the purpose. Why do we give bronchodilators in the first place? Dilate the bronchioles. So one of the biggest issues that we run into as respiratory therapists is something called bronchial constriction. Bronchioconstriction. Okay, bronchioconstriction. Now, are there different causes for bronchioconstriction? There's just not one cause, right? There are actually 3 major causes that we run into. And it talks about these causes in the book, but I just want to go ahead and emphasize them. Most of what I'll talk about today will be blue light special, unfortunately, just because it's such an important lecture. Okay, so the first thing that we run into spasm of the muscles, right? I have bronchiospasm. Okay, and we know that muscles line our bronchioles, or what we're known as our non-cartilaginous airways. Because our cartilaginous airways, like our trachea, our main stem bronchi, do they have significant muscle component? That is to say, can they actually spasm? No. It's only when we get lower into our non-cartilaginous airways, the lower generations, that we have to worry about bronchiospasm. Okay, so that's one cause. The other cause is inflammation. Okay, and what happens with inflammation? Well, I have cells, for example, mast cells. They degranulate, they release pro-inflammatory substances. Those substances are cell mediators, and they attract cells, and they say, hey, something's going on here. Cells, white blood cells come into the area. The vessels become leaky, or what we call permeable. They leak fluid out, I get swelling, I get all these cells flooding the area, I get more nutrients coming in, and I get inflammation. That, in a nutshell, is what's going on with inflammation. And then I also can have mucus production. Okay, my goblet cells can be stimulated, generally through inflammation or through the parasympathetic nervous system, and they can cause us to secrete lots of mucus. And that can decrease the diameter of our airways, right? If I have a bunch of mucus clogging it, I don't have as much space for air to move in and out. So these are the three major causes of bronchoconstriction. Where do our bronchodilators work primarily? Do they work here? Not really. Do they work here? No. They work here. Okay? They work primarily with bronchospasm. Now, if you guys are doing your drug cards, hopefully, because they're due next week, you hopefully have read about albuterol and that it may have some mast cell stabilizing effects. So it may affect a little bit here. But primarily the bronchodilators affect here. So if I have a patient that has excessive mucus production, lots of inflammation, do you think giving that specific patient albuterol is going to be particularly helpful? Maybe, maybe not. Maybe they do have some bronchospasm, but if they didn't, and this was their problem, lots of mucus, albuterol, is that going to be helpful? Not by itself, no. So we need to be very careful about what we give medications for, and we got to understand that the bronchodilators are for very specific issues, and those issues revolve around spasm. Now, in patients that have lung disease, specifically chronic obstructive pulmonary disease, COPD, and there are actually several different diseases that fall under there, do they generally have all three components? What do you guys think? Where they make mucus, they have inflammation, and they have bronchospasm? Absolutely. So as a general rule, yes, bronchodilators will help, but if I have significant mucus component or inflammation component of that bronchoconstriction, I need to look at other therapies for those. And we need to realize that bronchodilators alone may not be helpful. Okay, so we understand that. And we have three major classifications of bronchodilators. Okay? And we can classify them by time. By time. And you have some tables in your book that you can go ahead and look over. And the first time period are the short-acting ones. Short-acting. Okay, they have a short duration of action. Okay. These include medications that are copies or analogs of sympathetic neurotransmitters, like epinephrine, for example. Okay. These can also include some interesting medications that you won't see really given anymore, but you will see them on tests. Not my tests, but you will see them on other tests in this program, so it does bear mentioning them. And these include medications like isoethrin and isoprotenolol. And you guys have these in your tables, in your book. You guys did the reading before coming here, hopefully. You have these medications. These are the ultra-short-acting. These are very short-acting medications. That means they don't last very long. Would you guys agree? They don't last very long. They're very short-acting. The next class of medications that we have act a little longer, and we can call these our intermediate or our middle, if you want to call them that, whatever, intermediate action. These have a longer duration, anywhere from 4 to 6 hours. I should say that your short duration are going to be about 1 to 3 hours, right around in there. Our longer acting are going to be 4 to 6 hours. The big medications that we give in these intermediate acting medications will include things like albuterol, Xopenex, and I use I use brand name and generic names kind of interchangeably. So albuterol would be Proventil. And do you guys happen to know what the generic for Xopenex is? Starts with an L. Levalbuterol. Okay. These are the two big intermediate acting ones. And then we have something called the long acting. Long acting. Okay. These have a long duration of action. Up to 12 hours in some cases. So we'll just write a little up to 12 hours here. These can include medications such as Serovent. Okay, so let's go ahead and talk about giving these various classes of medications. So if I'm having a crisis, let's say I'm having an emergency, okay, and I'm having bronchospasm, and I need to break those bronchospasms. I need what we call rescue. I need to be rescued. Do you think giving something that's long-acting that takes a while to kick in is going to be helpful?
No.
What do you guys think? Okay. So giving Serovent, for example, to a patient that needs rescued would be a good or a bad idea? It'd be a pretty bad idea. It would not be a good idea. However, would giving something like epinephrine perhaps be a better idea? Sure. Okay. Also, let's say that I have a patient who is not in crisis, but has a history of bronchospasm, maybe they have asthma, and we want to prevent bronchospasm from occurring. We want to do what's called maintenance therapy, preventative therapy. Would it make sense to give them a short-acting medication like isoephrine every 1 hour? Or would it make more sense to give them a long-acting medication? What do you guys think? Absolutely. So, again, short-acting medications or shorter-acting medications are going to be more for rescue. My patient is in crisis. I need to rescue them out of that crisis. Versus my longer-acting agents, which are going to be for maintenance, to prevent the crisis from happening in the first place. Does that kind of intuitively at least make some sense there, guys? Okay, so those are the big points that I want to make, and we'll talk about doses and all that here in a little bit. I should say that I would like you guys to take an extra look at isoephrine and isoprotenolol as the ultra short-acting agents. Just because you do run into those in test questions, I'm not really going to test you on those agents because we don't really use them clinically, but I should mention that because there are questions that you'll run across perhaps in other classes about those medications. Okay, so I'll go ahead and open the slides. Everybody was able to get the slides okay? I ended up, because these slides I download these actually from Pearson, which is a publisher. I had to actually download them in packages, so did the package confuse anybody? If they did, this is package 1. If you open up package 1 on your links, you'll have the first 5 lectures in package 1, and then package 2 be 6. So just to give you a heads up there. Alrighty. So I'm going to be bouncing around back and forth. I'm not going to do totally PowerPoint today. I'm going to go back and forth between the board and the PowerPoint. I really try to limit the PowerPoint. I don't know how you guys feel about that, but I hate what's called death by PowerPoint, where somebody just clicks through there. Here you go, here you go, here you go. That bores me. It makes me very bored. I don't know how some of you guys are. Maybe some of you really like it, but I do like to at least mix it up a little bit. So. And pharmacology is probably not the most exciting subject to talk about anyway. I think it's exciting. I love talking about pharmacology, but perhaps not to everybody. Okay, so let's go ahead and, all right. So our objectives, all right, anatomy and physiology. You guys should be up on this, hopefully, right? What do you guys think? Up on your anatomy and physiology? Okay, so we have the mucosa. The mucosa is the innermost or the outermost layer within our airways. It's the innermost layer. And this is what contains the ciliated cells, right? The pseudostratified ciliated columnar epithelial tissue. I have my gel, my cell layer. I have goblet cells that secrete mucus. The goblet cells are innervated by which branch of the nervous system? The autonomic. Which branch of the autonomic? Yeah, parasympathetic, right? Yeah, because secretion. There you go. Good. Okay, so what kinds of receptors do you think? Going back to last. Nicotinic or muscarinic receptors? Muscarinic. There you go. Whenever I hear muscarinic, think glands and think sticky, yucky stuff. And you'll pretty much have a muscarinic response. Okay, submucosa. So this is the middle layer. This contains the glands, the smooth muscle, the capillary networks, and elastic tissue. And then I have the outermost layer, the adventitia, which is essentially connective tissue that surrounds and supports the airways. So we're going to be very concerned here in this discussion about the submucosal layer. Okay, so large airways, we know where they're at. In our large airways, do we have a whole lot of smooth muscle and bronchial spasm occurring? No, we don't, because they're cartilaginous. They have lots of cartilage in them, have lots of structure. Are they still prone to inflammation and mucus plugging, however? Yes, they are. Okay, so once we get into our bronchioles, our small airway, 1 to 2 millimeters in diameter, that lack the cartilage, or what we call non-cartilaginous airways, we get into this. And you guys have probably seen these pictures in your integrated anatomy and physiology books. And again, so I have my inner layer here, my middle layer, and then my outer layer. And I have these little crisscrossing bands of muscle there. Okay, so we talked about bronchoconstriction. There are 3 things that cause bronchoconstriction, right? I have swelling, mucus production, excessive mucus production, or spasm. Okay, this is what we care about here, bronchospasm. That's why we give bronchodilators. Spasm of the smooth muscle, airway diameter is reduced, causes a reduction in airflow and increased work of breathing. Next semester, we will discuss this mechanism in more detail, hopefully, when you guys take physics. And we'll talk about something called Poiseuille's Law. Anybody familiar with Poiseuille's Law? Anybody a firefighter here? No? I thought there was at least a firefighter here. Hopefully when you went to the fire academy, they talked about Poiseuille's Law, because it's very important when I talk about pushing water through hoses. Yeah. So, yeah. All right, edema, we know what occurs with edema, generally speaking, and secretions. Okay, what do you know? We have a picture here, lots of secretions. Can't get air in and out of those little guys. All right, sympathetic nervous system, you guys know what that is, hopefully, right? We spent a fair amount, almost 2 hours talking about it last week. I'm not going to spend a whole lot of time reduxing this stuff. Parasympathetic, mucus, bronchoconstriction and spasm, those are all parasympathetic responses. Okay, balance. It's a kind of a neat picture. They're not fighting each other though, right? They're not fighting, they're complementing each other. There's a balance. Okay, parasympathetic versus sympathetic. Which branch of the nervous system primarily innervates our lower airways? Our lower airways are primarily innervated by which branch of the nervous system? Sympathetic or parasympathetic? Parasympathetic. The parasympathetic nervous system actually dominates our lower airways, believe it or not. And this makes some intuitive sense, because do I need mucus to be produced? Yes. Do I need to have bronchospasm in some cases? Or not spasm, but do I perhaps need to decrease the size of my airways in some situations? Yeah, sure. If I have lots of particles or irritants or things like that, it can be a protective mechanism. Interestingly enough, I read an article where a gentleman had wrote about the bronchospasm, it being kind of like the appendix of the lungs, that there's really no physiological need for bronchospasm. And from what you guys know of anatomy and physiology, does our body generally have something it doesn't need? Okay, if there's generally, other than, cancers and things like that, neoplasms, generally our body has an organ or does something because we need it. It helps us out in some way. And in fact, do you think the appendix is potentially helpful? We're actually finding that, in fact, the appendix may have some potentially helpful functions in the body. So it may not be quite as worthless as we thought. But if I ever had surgery in my abdominal area, I would probably tell the surgeon, hey, while you're there, do you mind yanking the appendix? Just so I don't have problems later on. Okay, sympathetic versus parasympathetic. These are the neurotransmitters. I actually received a question about this. And so somebody was asking me, what's the difference between an endocrine function and a nervous function? Because the endocrine system can use a neurotransmitter, right? Sometimes, like epinephrine and norepinephrine. Those are endocrine hormones. But they're also neurotransmitters, so what's the difference? The difference is the endocrine system will generally secrete a hormone. That hormone will go into the bloodstream, and the bloodstream will circulate that hormone to where it needs to go. Does that make sense? The nervous system doesn't do that. The nervous system wants to control something. It has a nerve that goes directly to the target and dumps neurotransmitter onto the target. Does that make sense? So that's the difference between the endocrine and the nervous system, is that the nervous system is a little direct controller. It has a nerve that goes directly there. The endocrine system can secrete somewhere in the body, and those hormones will be circulated to other areas of the body. So that's really the major difference. It's a bit more subtle than that, but that's the major difference. Okay, alpha, beta 1, beta 2. Where do alpha receptors, where do we care about them working?
Arteries.
Okay, blood vessels, arteries and veins. And what can they do? Vasoconstriction. Good. How about beta 1 receptors? Where do they work? In the heart. Beta 2? In the lungs. All right. So alpha receptors, artery, veins, vasoconstriction. Beta 1 in the heart. Beta 2 receptors, bronchial smooth muscle. All right, here you go. You've got a table, same table that you guys have in your book. Sympathetic nervous system in the lungs. You do have some sympathetic innervation. And there's just kind of another table, and it talks about the effects and parasympathetic and sympathetic, patholytic, and sympatholytic. Compare and contrast. Did we do this last week? Yep, we sure did. Bronchodilators. Okay. I talked about time. We divide them into time. We can also divide them into their mechanism of action. And I have something called my sympathomimetics, my anticholinergics, and my xanthine derivatives, or my xanthines. So what I'm going to do is I'm going to write them up here for a little later, and just so we can do a recap. So we're going to have our sympathomimetics. Okay. We have our anticholinergics, and we have our xanthines, or xanthine derivatives. Okay. Bronchodilators. Bronchodilators. I'm going to turn this on standby for now, and I'm going to go to the board to explain this because it'll be a lot easier than trying to explain it off of a slide. And this is where we get into the real deal pharmacology. I like this part. I really like this part a lot. Okay, so, and this is one of the few places where you're going to get this. And that's why I like this so much. Everywhere else, you won't get this, but we'll get it here. How does a sympathomimetic bronchodilator work? It's a beta agonist. Okay. What happens after I attach to a beta receptor? Let's talk about that. Let's talk about that. This is really interesting. Okay, so if you guys can imagine, this is my cell membrane here. Okay, this is, I'm going to make it very simple, obviously. It's going to be simplistic. This is my beta receptor here. The beta receptor actually belongs to a class of receptors known as TM7 receptors, or transmembrane 7 receptors. You don't have to memorize that. And it doesn't look like this. What the TM7 receptor, what these receptors literally look like is they literally go through the membrane several times, well, 7 times, and they have a really interesting shape. But we're going to keep it simple. Okay, so I have a beta 2 receptor here, okay? And I have a beta agonist, a sympathomimetic, okay, like epinephrine, we'll say. And it's going to attach to the beta receptor. You guys would agree? And is it an antagonist or an agonist for a beta 2 receptor? An agonist, a beta 2 agonist. So it is going to attach to the receptor, and what is it going to do to that? What's going to happen to that receptor? The shape, because what is this receptor? What is it? What is it chemically? What are receptors? Proteins. There we go. They're proteins. And what did I talk about proteins? What's special about proteins? Their shape, right? Mm-hmm. And it started with a C. There's a special word. Conformation, right? Conformation. Mm-hmm. It's a special shape that a protein takes. And when I change that conformation, change the shape of a protein, do I change the way that it can act? Yes. Yes, I can. And that's what happens here. And the lock and key analogy is what I gave. Kind of like a lock and key. I put the key in the lock. It fits perfectly. And then I turn the key. And do I change the shape of that lock mechanism? If you were to look at the lock mechanism, would the shape change? Yeah. You know, the little post sticking out would suck in and you could open the door out. So yeah, it would change. Something similar happens here. Not quite like that, but the lock and key analogy works good enough here. The conformation of this receptor changes, and that causes a whole bunch of things to occur right here at the membrane. Okay? That change activates something called G proteins. And I know if you guys are good at molecular biology, you'll say, oh boy, Chris, there are lots of different kinds of G proteins. Let's just keep it simple. G proteins. Okay? And then G proteins cause some interesting things to occur. Okay? We have ATP being broken down into CAMP. You guys know what CAMP is? You guys heard of that? Yeah. Okay. So it's an intermediate molecule. It's known as a cyclic 3' 5' adenosine monophosphate. You can see why we call it CAMP. Yeah, it's a little easier to say than cyclic 3' 5' adenosine monophosphate. So, and I should say that there's also another protein called adenyl cyclase in here that G proteins act on. ATP turned into cyclic AMP, and that acts to cause the bronchodilation. The dilation to occur. A couple of different mechanisms. It, first of all, decreases calcium. And what do we know about calcium? Is calcium important with muscle contraction? Yes. It is, right? Because we know that when I have muscle contraction, calcium flows out of the sarcoplasmic reticulum, and it helps open up binding sites on actin and myosin, and that allows actin and myosin to come together, the cross bridge to link together and to contract. So we're not going to go that deep for this class. We're not going to talk about calcium, the role of calcium specifically, other than that is involved. And we're not really going to talk about, I believe it's a tropomyosin binding sites and all that. Just know that I give a sympathomimetic medication. It attaches to a beta, in this case, it could be a beta-1 receptor, it could be an alpha receptor, but we're worried about beta-2 receptor. G proteins are activated, which activate adenyl cyclase, which helps convert adenosine triphosphate, ATP, to cyclic AMP, and that ultimately leads to bronchodilation. Allows those muscles to relax. Is everybody okay there? And on tests, they often like to ask, they will throw these different words out. And one of the relationships that they want you to be familiar with is this one here, with cyclic AMP causing bronchodilation, involved in that. Sometimes when we talk about the parasympathetic nervous system causing bronchoconstriction, instead of CAMP, we will use GMP. I'm not going to go ahead and draw out that whole pathway because I want you guys to know this pathway. But often we need to realize that GMP is associated with bronchoconstriction or spasm. So let's just go ahead and review this one more time real quick. Beta-2 receptor is activated by an agonist. Okay? Its conformation changes. G proteins are activated. G proteins act upon adenyl cyclase. That acts to cause ATP to turn into CAMP, and that causes bronchodilation. Okay? You want me to leave this up here for just a bit? You guys okay with that basic pathway? And we don't have to go in any more depth than this. And just know that CAMP is associated with bronchodilation. GMP is associated with bronchoconstriction. Okay. Just know that CAMP and GMP aren't medications that we give. They're cellular messengers. They're intracellular messengers that are involved in dilation and constriction. Okay, good. Good. All right. So we'll go ahead and pull the PowerPoint back up again. So we talked about the sympathomimetics and the pathway involved. We also have anticholinergics. What do anticholinergics do? What is their action? They antagonize what? The parasympathetic nervous system. Okay. They block the parasympathetic nervous system. So can they cause bronchodilation? Sure. Do you think they directly cause it, however? Do they directly? They don't directly act on sympathetic receptors, right? So our anticholinergics don't directly cause bronchodilation. So do you think that an anticholinergic medication would be a great choice for rescue medication by itself? No, because they're not direct acting. They do act directly on the parasympathetic nervous system by blocking it, but they don't act on the sympathetic nervous system, right? They're not sympathomimetics. So when I need to rescue somebody, I want to make sure that I give them a rescue medication or a sympathomimetic. I may add an anticholinergic in there, but I will not give an anticholinergic by itself in most cases. Okay. Both sympathomimetics and anticholinergics can be administered as inhaled aerosols. And then xanthines act as weak bronchodilators. And these are what we call our back door. They work by some interesting mechanisms we'll talk about here in a little bit. They're generally taken orally or intravenously. What are some examples of xanthines? You guys probably all had it this morning in some form. Caffeine. Caffeine is kind of like the mother of all xanthines. And all of our xanthine derivatives are essentially structurally very similar to caffeine. And yes, caffeine actually has very weak bronchodilating actions as well. Okay, so sympathomimetic or adrenergics. We know we get alpha, beta 1, and beta 2. What are we most interested in? Beta 2. Okay, beta 2. Do we care about alpha and beta 1 though? Yes, because certain medications will have more alpha and beta 1 effects than others. And if I have somebody with, let's say, cardiac problems, do I want to necessarily make them tachycardic by stimulating beta 1? So my choice of bronchodilators, I may need to choose very carefully what I give certain patients. Okay, we talked about the mechanism of action, adenyl cyclase, cyclic AMP. So beta receptor, the stimulatory proteins, these are G proteins. Adenyl cyclase is activated. That causes the conversion of ATP to cyclic AMP. Cyclic AMP relaxes smooth muscle, okay, and it inactivates enzymes, and it decreases levels of calcium. Okay, there you go. Hey, what do you know? Already talked about that. There are some anti-inflammatory properties, okay, and so there are some very weak anti-inflammatory properties that occur with some of these medications, but that's not their primary. That's not primarily what they do. Cyclic AMP can be broken down by the enzyme phosphodiesterase. And there is a certain class of medications called phosphodiesterase inhibitors. We give them, they inhibit this enzyme, and that allows cyclic AMP to remain in its active form for longer, and these become a little more important in other classes of medications that we'll talk about a little later on. But we will come back to this phosphodiesterase and phosphodiesterase inhibitors. Okay, yep. So cyclic AMP causes dilation, and cyclic GMP or GMP causes constriction. All right. And this is, AMP is associated with sympathetic and GMP parasympathetic. Okay. All righty. So the earliest types of beta agonists, the catecholamines. The catecholamines. What are the three components of a catecholamine? You guys remember this from last week? Benzene ring, 2 hydroxyl groups, and an amine side chain. Okay, that is a catecholamine. Okay, the nucleus is made up of a benzene ring, 2 hydroxyl groups, and if now the catecholamine, that is exactly what a catecholamine is. So epinephrine, norepinephrine, things like that are catecholamines. They have all 3 of those properties. Now, can we modify those properties maybe just a little bit? Maybe I modify this side chain. Maybe I modify the hydroxyl groups. Will I still have a molecule that can affect the sympathetic nervous system? Sure, but will it maybe work a little differently? Yes. And what we found is with the catecholamines, they're very quick to act. We like that. They're quick acting. But do they last very long? No, they don't. And do the catecholamines, for the most part, really care about receptors? What do you guys think? That is to say, if I have a patient with heart problems, and I want to target just the beta 2 receptor, and I want to leave the beta 1 and the alpha 1 alone, are catecholamines going to do that for us? No. Catecholamines attach to all, for the most part, all of the sympathetic receptors. If I give somebody epinephrine, that epinephrine is going to attach to alpha 1, to beta 1, and beta 2 receptors, all alike. So in that patient with cardiac disease, or maybe hypertension, do you think a catecholamine would be a great idea to give them? No, because we may cause tachycardia, we may cause hypertension. Also, if I have a patient who's already tachycardic, would I necessarily want to give a catecholamine? No. But catecholamines were the first medications that came out for treating bronchospasm. Well, other than things like coffee, caffeine back hundreds of years ago, probably thousands of years ago. Okay. Get back to where we were here. All right. So we realized, hey, if I can change the benzene ring a little bit, do I change the ring itself, though? No. I either change the amine site group or the hydroxyl groups. I add stuff or I take stuff away. So if I can change that molecule, I can get a couple of other classes. I can get my resorcinols, or I can get my saligenins. Now, what do all three of these have in common? What one structure do all three of these have in common? The benzene ring. They all have the benzene ring, but it's how we change the groups. If I change the group a certain way and I get a different class, I can have very different effects occur. And here's just a picture, and I drew this last week for you guys. This is the benzene ring, 6 carbons. I have a hydroxyl group, and then I have an amine side chain, and amine, of course, is a nitrogen group here. Okay, that's the basic catecholamine molecule. Here are a couple pictures. You're not going to have to memorize this, okay, guys? You're not going to have to memorize this. But this is just talking about a catecholamine. So right here, this is called the catechol structure, the benzene ring with the 2 hydroxyl groups. Everybody can see that? Okay. And then obviously the side chain would be the amine, catecholamine. Okay. So can everyone see this here? And this is right out of your book. This is an epinephrine molecule. Right here? Everybody's okay with that? Epinephrine molecule, very typical catecholamine. Now what I'm going to do is I'm going to move down to the resorcinols here. Okay? And what did I do with the resorcinol? See the hydroxyl groups? I changed. See this one in the middle here? It's not there, and instead it went down to this other carbon here. Did you guys see that? And I made some slight modifications to the amine chain. See here, it just ends with a CH3 on epinephrine. I have a CH2, CH2, CH2. I have 3. So I've made pretty minor changes if you think about it. You know, a couple, basically carbons, oxygen, hydrogen, I just swapped them around a little bit. But what I got here is I got something very different. So, what I got when I changed this, the resorcinol molecule, and I'll use terbutaline here, or brethine, as the molecule to represent this group, because this is one that you will give occasionally, terbutaline and brethine, is I get a medication that has a longer action, because remember, these are only about, what, 1, 2, 3 hours? The isoprotenolol is really short-acting, 1, 2, 3 hours, whereas these guys are now into the 4 to 6 hours. And I get terbutaline here, and metaprotenolol as well. These resorcinols have a longer duration of action, they're harder to degrade, and what enzymes degrade catecholamine-like molecules? You guys remember what 2 enzymes? Monoamine oxidase, MAO, and then COMT. Yeah, COMT. Okay. So, longer duration of action and more beta-2 effects. So instead of my epinephrine up here affecting beta-1 and beta-2, I now have more beta-2 than beta-1. Is that a good thing? Sure, I have less cardiac effects with my resorcinols. Okay, everybody's okay there? Now, if I modify, we'll go back to the catechol here, the nucleus, and then of course the amines, the side chain. So I have my hydroxyl groups. Now, let's go ahead and put an HOH2C group here at the bottom. Everyone see that? So I took this one out and did this, and then made some slight modifications to the side chain. This is called a saligenin, or saligenin, however you want to pronounce that. And the medication that is representative of this group is going to be albuterol. Zopanex or levoalbuterol will also fall into this group. Everybody's okay? Just like the Resorcinols, the saligenins have more beta 2 and less beta 1. Good thing? Yeah, very good thing. Good. They have the longer duration of action, the 4 to 6 hours versus the 1 to 3. So the Resorcinols and the saligenins are very similar in the way they work. Very similar, very slight differences. And really all you can see is just very slight chemical changes to the side groups or the amine chain. But the one constant that always remains, the one constant is the benzene ring. The benzene ring always remains. It's very tough to break a benzene ring up. Okay, and then this is just talking about a really long-acting beta-2 salmeterol, Ceravent. There are a couple of other ones. You can see that this is actually really interesting. I have two benzene rings, and I have some interesting side groups there. Okay, it's a really long-acting. It's really hard to break this down with COMT or MAO. Okay, so Resorcinol. Again, guys, I'm not going to go into this in a whole lot of detail. I'm not going to make you draw this on an exam, like, hey, draw the Resorcinol groups out. Okay, I just want you to be aware of that's what we're doing, is we're making relatively minor chemical changes, but I'm having very drastic effects occur. And primarily what we're looking at when we go to the newer groups of medications, when we get away from catecholamines, we're looking at more beta-2 and less beta-1 and a longer duration of action. Okay, chemical history. Okay, so catecholamines, the oldest group of inhaled bronchodilators, sympathetic, deactivated by COMT and MAO, cannot be given orally because they're degraded by the GI tract. So you won't give somebody epinephrine orally, for example. Has anyone ever heard of that? No. Outside of the United States? Nope, doesn't happen. Now, examples of catecholamines: epinephrine, norepinephrine, racemic epinephrine, dopamine, isoprotenolol, isoethrin, bilateral. I probably butchered that enunciation. The things that I really care about right now are going to be epinephrine and racemic epinephrine. I would review isoprotenolol, isoethrin, just because they're ultra short acting and they come up on tests. Norepinephrine and dopamine, we generally don't give nebulized. These are generally given in the IV to help patients that maybe have really low heart rates or have really low blood pressures for certain reasons. These are what we call vasopressors. And we will talk about them in our cardiac drugs lecture, a little more detail. So epinephrine, racemic epinephrine, and then just go ahead and review the isoprotenolol and isoethrin. Okay. Isoethrin, bronchosol, bronchometer. It's inactivated by heat, light, and air. It can turn pink when that happens. Okay, racemic epinephrine. Okay. What does racemic mean? What does it mean? Right. What it means is a 50-50, a 1-to-1 mixture of right and left-handed isomers or enantiomers, right? That is what a racemic mixture is, a 1-to-1, a 1-to-1 mixture. Racemic epinephrine we give, where do we want racemic epinephrine to work? Upper airway or lower airway? Upper airway, right? We give this primarily for what? Bronchodilation? Mucus? Or inflammation? Upper airway inflammation or edema. And you will see this given to little kids that develop croup. Have you guys talked about croup yet? Somewhat? Okay, you will in a little more detail. But croup is generally a more of an upper airway, a subglottic upper airway problem. It's a viral infection. And what do they get? Well, they get inflammation and narrowing of their upper airway. Also, patients that have been intubated. Sometimes when we extubate them and take the endotracheal tube out, they can have some irritation and get a little edema. You may give racemic epinephrine there. So since racemic epinephrine is a catecholamine, will it affect more than just beta 2 receptors? Well, yeah, because we're actually not even giving it for its beta 2 effects, are we? We're giving it for its alpha effects. So it's going to affect alpha, beta 1, and beta 2. So am I going to get tachycardia? Am I going to get some elevated blood pressure potentially even though I'm giving it inhaled? Yes, I am. Tachycardia can be a problem with racemic epinephrine. Okay, toronolate or bidolitrol. It's interesting. You don't see it given a whole lot. However, they love to talk about this on exams because this is what's known as a prodrug. Do you guys remember from the first lecture when I talked about certain drugs certain drugs were inactive when we give them, and it wasn't until after they'd been metabolized into their active form that they worked? You guys remember that from the first lecture? That is what we call a prodrug. If I give it, it is inactive initially. I think I used the codeine as an example. I give somebody codeine. Codeine doesn't have any narcotic effects until after it's been metabolized into its active metabolite. This medication is the same way. It is administered as in an inactive form, and it's converted to its active form. And that's called a prodrug. And that is one of the only prodrugs that we run into. Even though you really don't see it given a whole lot. They still like to talk about this on exams, similar to albuterol in the way it acts, other than it needs to be metabolized into its active form.
Why don't they give a lot?
What's that?
Why don't they give a lot?
I don't know if it's cost effectiveness, if it's maybe expensive, if it has maybe some side effects that they don't like. Maybe it might be a little more difficult to make, or maybe the enzymes that we need to convert it into its active form, maybe that becomes an issue in certain patients. That would be my guess. And it's just probably easier to give safer medication, not necessarily safer, but medications like albuterol. And it could just be that's what people like to give. We'd like to give albuterol. We're used to it. Again, I'm not particularly familiar with this medication. I've never given it in my entire career of 15 plus years. I have never seen this medication given. This is not to say that it won't ever be given, but I've just never seen it given. But they do like to ask about it being a prodrug. Resorcinols are resistant to breakdown by comp, so they're longer acting, and these examples would be terbutaline would be a good example of a resorcinol. It can be taken orally, so you can see these given orally. And first maintenance drug for the treatment of reactive airway disease, because they have a longer duration of action. Less beta-1 effects. Do you think they make a little better longer treatment, or we call maintenance drugs? Sure. Okay. Metaprotenolol is an example of a resorcinol. It's more beta-2 specific. Here I have a longer duration of action, 4 to 6 hours. Onset of action is 5 to 15 minutes, so its onset is a little slower than the catecholamines, like epinephrine, for example. But it has a longer duration of action. Cardiac side effects, because it is similar to isoprotenolol, so I'm still going to get some cardiac crossover, and I'm still going to get tachycardia, maybe not as much as the catecholamines. But okay, terbutaline or breathine. Beta-2 specific, longer acting, again, about 5 to 15 minutes, 4 to 6 hours. This is available as an MDI. And anybody here ever been given terbutaline for something other than airway problems? Nobody here? Anybody here have kids? No? Wow. Anybody here have problems with going into labor a little too soon? Preterm labor? do we have smooth muscle in our uterus? Well, people that do have uteruses, do they have smooth muscle? Does that exist?
So is this the drug that they give you to work that out?
There you go.
I have seen people
Yeah.
get shaky.
Mm-hmm. We also will give terbutaline to patients that were worried about going into labor too soon or premature labor, because do we have smooth muscle in our uterus? What do you guys think? Yes, absolutely. I can give terbutaline, and I can relax that smooth muscle and help prevent them from going into preterm labor, or help arrest or retard that labor if it were to occur. So sometimes you will see people given terbutaline, not necessarily for its bronchodilation effects, but for its its effects, other types of smooth muscle.
So they give it through an IV then?
Often they'll give an injection, like subcutaneous injection. Yeah. The saligenins are the most recently developed. They're the newer, the most widely prescribed type of bronchodilator. They're actually pretty easy to make and very cheap. Albuterol is very cheap. It's actually pretty cheap in the United States. I actually I go to Mexico to get my medications, and it's exceptionally cheap there. But not that I condone doing that. But anyway, it's widely prescribed, pretty easy to make, very cheap. You find it all over the world. It's not called albuterol. Outside of the United States, it will not be called albuterol, however. Outside of the United States, we name it after its chemical structure, the saligenins, and it'll be called salbutamol. You don't have to memorize that, but salbutamol is the common name, generic name outside of the United States. Albuterol is a common name in the United States. Okay, very similar to the Resorcinol's, duration of action is almost exactly the same, 4 to 6 hours. Okay, albuterol, frequently administered, very few side effects. It has a long side chain, so it lasts a while. Peak effect in 30 to 60 minutes. That's not to say that it doesn't start working within a couple of minutes, but its peak effect takes about half an hour to work and has a longer duration. You can give it orally, and sometimes we'll see given as a syrup or tablets, extended release tablets. We can also nebulize it. We can give it in a metered dose inhaler, and even dry powder inhaler form. So we see albuterol all over the place. Prebuterol or Maxair, you don't see this given as much, but it's there, it's around, less potent than albuterol. You see this as a breath-actuated inhaler. Salmeterol or Serovent. Salmeterol is a little different in that it's lipophilic. Okay? It's lipophilic, and that means it likes lipids. And do you guys remember the structure of the salmeterol in the picture? It had that really, really long carbon-hydrogen chain in between the two benzene rings. Really long carbon-hydrogen chains, are they generally charged or non-charged? Are they generally polar or non-polar? They're generally non-polar, right? And if you guys remember from chemistry, there's a lot of what we call London dispersion forces occurring there. And that was, I don't know if you guys remember from chemistry, they're like, oh, look for lots of carbon-hydrogen chains for looking for London forces. And that's because they're non-polar. There's not really a whole lot of separation of charge. And non-polar molecules, do they like fat? Yes, they do. They like fat because polar molecules like water, right? Non-polar molecules like fat, so that long chain can help it diffuse into the phospholipid membrane, enter the receptors from the lateral approach, and because it's kind of in the membrane itself, it's highly resistant to being broken down. It's kind of protected by the membrane. Does that make sense? And it can last up to 12 hours of action. So it's ideal for maintenance use, but do you think it takes a little while for it to actually diffuse into the layer and attach to the receptor and all that? Yes, so its onset is very long, so it's not good for rescue medications or for rescue use. It's good for maintenance use, though. Okay, slow onset. So if they're having an issue, you want to go ahead and rescue them with albuterol. And then give the Serovent or Salmeterol as a maintenance medication. Let's go ahead and take a break, guys. Let's take 10 minutes, and we'll come and talk about levoalbuterol and finish up with anticholinergics and xanthines.